teacher honorarium for all types of health education in our community, including physician, nurses, nurse practitioner, PAs, dentists, and EMT providers. You will receive by email and or through your logging or clicking on a QR code an evaluation form. We ask everyone to complete that after the program. For nurses and nurse practitioners, you must complete that to get your credit. Otherwise, the form's voluntary for everyone else. We do want you to take a few minutes to fill it out. Question number 4 asks, what will you change in your practice based on what you learned this evening? And that is for everyone, not just the providers. We all practice our craft in medical care based on our scope of practice. In addition, you'll be asked to re-enter your name, your email address in the evaluation form questions. That allows us to email you your CME certificate for your attendance. So please give us your full name, no short names, nicknames, etc., because that's what will appear on your certificate. A special note to any pharmacists or PharmDs on our call tonight, your professional organization will recognize the physician category 1 credit if you submit it to them in your required number of hours of pharmaceutical CE, because Dr. Jones will be talking about drugs in his presentation this evening. There will be a QR code as shown here. If you're a QR code type person, you can use that to access basically the eval form. Sovah medical residents, you do not have to keep up with your CME certificates. Your coordinator will do that for you. We will send them the fact that you were a participant in that. And then every time we have a program, I take just a moment to thank Vinay Mayo, our CME coordinator, and Jennifer Goodman, our nursing educational coordinator for these programs. They are really the ones that do the heavy lifting, the magic behind the curtain, and I'm very grateful for their help when we do these programs. Dr. Jones encourages questions for you. I will give you one little other disclosure. He is a little time limited. He has to go to another call at 8 o'clock. But if you have questions, please put them in the chat. And if there's any he doesn't have time to address, I will do my best to help with that if the time runs out. I want to highlight for you very briefly our upcoming CME programs. Next Tuesday night, February 17th, we will have the first in medical history, if it were, our first nursing-centric evening Teams-based CME program that Jennifer has arranged. This first one will be on understanding ECO and TDO processes. You can see the speakers listed below. Announcements have been sent out through the internal Sovah Health notification. If anyone on the call who's not a member of Sovah Health needs an invitation, if you'll reach out to me or Jennifer, we'll be more than happy to get it to you. In 2 weeks, on Thursday evening, we will have another guideline consensus program. David Katlaba, a member of the Duke faculty who practices and lives here in Danville, will review the current American Heart Guidelines for optimizing medical management of heart failure. And then in the second week in March, we will have the first in what this year will be a new series of quarterly emergency medicine programs. Dr. Newby, who's an interventional cardiologist at Duke, will be talking about variations in how acute STEMIs present based on symptoms as well as EKG findings. That being said, I'm delighted to have Dr. Daniel Jones from the University of Mississippi as our speaker this evening. He is the chairperson for the most recently released 2025 American Heart, American College of Cardiology guidelines for the detection, prevention, evaluation, and management of high blood pressure in adults. This is an evolution, as he'll be telling you about a little, from the previous long series of JNC reports on high blood pressure. He began his educational journey at the Mississippi College. Following that, his medical school training as well as his internal medicine residencies were done at the University of Mississippi in Jackson, Ole Miss as it's known. There he was selected due to his academic excellence for the AOA, the Alpha Omega Alpha Society, a distinct honor. He then went into private internal medicine practice in Laurel, Mississippi for a number of years until he became a medical missionary for community health department and the hypertension clinic at the Wallace Memorial Baptist Hospital in Busan, Korea. He was there 7 years before he was recruited back to Ole Miss to begin an administrative academic medicine role that led to his becoming not only a full professor of medicine at Ole Miss in the School of Medicine, but actually the dean. And that was followed by serving as the chancellor of the University of Mississippi. During that period of time, he was also very active in the American Heart Association and served as the national AHA president in 2007. He has received numerous outstanding teaching awards from Ole Miss, as well as serving on numerous editorial boards and various sets of consensus guidelines. He is chairing this working group that brought this report to us. We have, over the past 20 years, been able to have these joint commission and consensus guidelines presented to us here in Danville and Martinsville at the community hospital level. And tonight it's a delight to have Dan present this one to you. So Dr. Jones, if you bring your slides up, you will knock mine off and we are ready to go. Thanks so much.
All right, Mike, thank you so much. I'm struggling to get my screen shared, but I'm sure it's eventually going to get there. So I'm hitting share at the top, but the file that I want is not coming up, even though I have it open on my screen. I'm going to keep trying. While I'm doing that, let me share that I've looked forward to this particular event for two reasons. One, as Mike pointed out, we've been friends a long time, and it's rare that I get to be hosted by someone who is also an expert in hypertension. And indeed, Mike could answer all of the questions that you might have better than me. And so, Mike, it's a privilege to be with you, and thank you for this invitation. The second is that most of the presentations I've done in the last few months since the guideline was published were related to academic centers and grand rounds to departments of medicine and so forth. And I'll just say that I'm very happy to be presenting to a group that includes a number of primary care clinicians. You may have picked up in Mike's presentation that my life in medicine began as a primary care clinician, and it's still my identity. Even though I've had lots of other titles along the way, I still consider myself my identity as a primary care clinician. I'm proud to have been the first primary care clinician to have led the committee process for writing blood pressure guidelines. I'll say that I hope my influence in that has led to a practical guideline that will be useful to you, and I look forward to sharing that with you. So, Mike, I just can't get my slides up. Can you guys?
Yeah. Hey, can you bring them? Can you bring them up, or I can either one? Just tell me what you prefer.
I can bring them up.
Okay, thanks so much.
And I'll just tell you when to change them, if you can do that.
Now, how do I?
Yeah. So while she's getting there, this you'll see in the first slide or two. This is a joint process between the American Heart Association and the American College of Cardiology, but there are 11 other participating organizations, including the American Medical Association and a number of other organizations, Society of General Internal Medicine, et cetera. Pleased with the collaborators. We had a great committee process, and again, I'm proud of the product, and I hope that it's useful to you in your practice. The guideline, as Mike mentioned, is an update of previous guidelines. So every 6 to 8 years, there's a new national guideline that is produced. For years, these were produced through the National Heart, Lung, and Blood Institute. Let me stop there for just a second and see. There we go. Here come slides. I hope. By the National Heart, Lung, and Blood Institute. And during that time, the nomenclature was JNC 1, 2, 3, 4, 5, 6, 7. All right, why don't you go on to the next slide if those are my slides that you have up?
It's not it.
Yeah. So I joined the guideline process in the mid 1990s and participated in JNC 7. JNC 8, some of you who have gray hairs like me will remember that that one didn't quite make it like it was intended. That there was really not an endorsed report. And then National Heart, Lung, and Blood Institute, partly because of the challenges in that guideline, asked the American Heart Association and American College of Cardiology to assume responsibility for the guideline process. Okay.
It's a second.
All right.
I think I got him. Let's see here.
That slideshow is showing one of one, so that's not his entire deck.
Hang on, hang on. There you go. Dan, can you see that?
There you go. Yeah, got it. Thanks. Go on to the next slide, if you will, Mike.
I do. Let's see.
Yeah. All right. So I'm a Mississippian speaking to Virginians. I know some of you thought, can't Mike do better than to get some guy from Mississippi to talk about blood pressure? But Mississippi and Virginia have some things in common, and these are two of my favorite people that we have a connection with. So William Faulkner on the left, of course, is a internationally known writer of literature, and he indeed is from Oxford, Mississippi. And in a dirty move, the University of Virginia recruited him away from the University of Mississippi late in his career after he was already famous. I'm trying to forgive Virginia for that. And then on the heels of that, we home grew another great writer, John Grisham, a popular writer. And John has been a great supporter of our university for a number of years. And doggone if he didn't wind up in Charlottesville, Virginia as well, just like Mr. Faulkner did. So anyway, I hope you guys enjoy Mr. Grisham. He's not only one of my favorite authors, he's one of my favorite people. And I know that he's an asset for you in Virginia. Next slide, Mike. So this one, Dr. Arthur Guyton, I'll talk about for other reasons, but tie it a little bit to Mr. Faulkner. So I bring Dr. Guyton up because he's the most famous person from the University of Mississippi, and some of you know him because of his textbook. Mike, if you'll go to the next slide, and then I'm going to have you hold there for a moment. Many of you might have studied Guyton's textbook of medical physiology in medical school. It is the medical textbooks that's used in more medical schools than any other medical textbook, not just physiology textbooks, but any textbook. And Dr. Guyton began writing this in 1956 from his class notes from his physiology course at the University of Mississippi. I don't know anyone who has a more interesting background than Dr. Guyton had. He was raised in Oxford, Mississippi, the home of the University of Mississippi. Lived just around the corner from William Faulkner. He and Mr. Faulkner shared a love of sailboats. And Dr. Guyton, from an early age, was an inventor, and he built a sailboat for Mr. Faulkner, and they shared that on Lake Sardis outside of Oxford for a good number of years. When the medical school, well, it was a 2-year school for a number of years, like a number of medical schools in rural states. Our students would go 2 years to get the basic sciences, and then they would go to another medical school to get their 3rd and 4th year. So Dr. Guyton grew up in Oxford. His father was dean of the School of Medicine, an ear, nose, and throat physician. He did his undergraduate work at Ole Miss and then went to Harvard, the medical school, and then was in the Harvard surgery program at the Brigham in his last year when he contracted polio, affected his arms and his legs, and he was for the rest of his life either in a wheelchair or on crutches. A remarkable man. He didn't let that slow him down. Came back to Mississippi without a physiology degree. He was a physician and partially trained as a surgeon, and asked the dean of medicine if he could teach physiology. And our dean at that time, Dean Pankratz, made a bold decision to let this unqualified man become chair of our Department of Physiology. And anyway, good things have happened since then. Dr. Guyton died a few years ago. His successor, John Hall, still chairman of physiology now. Dr. Guyton joined the faculty as chair of physiology in the late 1940s, and Dr. Hall succeeded him. And between the two of them, only those two men have chaired that department for 75 years. The other name on the current version of the textbook, the current edition, the 14th edition, is Michael Hall, who is John Hall's son, who is our chairman of medicine at the University of Mississippi. Next slide, if you will, Mike. So this is a slide of Dr. Guyton on his crutches, along with his wife, Ms. Guyton. And you might think these people in white coats behind them are Dr. Guyton's lab assistants, but indeed those are their 10 children, all 10 physicians. And I can't imagine how much pressure that last one, Jeannie Guyton, felt when the other 9 had gone to medical school and successfully matriculated. But all 10 and such a grand family and such a grand history. We'll look a little bit later at one piece of Dr. Guyton's research. I promise I won't give you a lot of pointy-headed stuff from an academic position, but there's one thing, a review of some physiologic principles that Dr. Guyton introduced us to that will be useful to you. Next slide, Mike. All right, let's go to the next slide. I think I've covered that. The committee is made up of 28 members, very diverse in background, professional and personal backgrounds, and a remarkably good group of people to work with. Yeah, next, Mike. So this guideline was written by clinicians. All 28 of us on the committee are clinicians, and it was written by clinicians for clinicians, and we hope evidence-based, but with practical application for use in your practice. Next slide. As I mentioned, this is a revision of the most recent guideline, the 2017 guideline. So there's the history from 1977 to 2025. This is the 10th. Mike wants me to call this JNC 10. That's not the nomenclature that the Heart Association chooses to use, but in my view, it is JNC 10. Next slide. So I'm going to give you a couple of things that I think are really important that come from the recommendations from the guideline. The first one is to give you the incentive to really be serious about controlling the blood pressure in your patients and to try to get your patients serious about controlling their blood pressure. And that is new information that's been developed since the 2017 guideline. That is absolutely clear evidence that intensive lowering of blood pressure to lower than 130 reduces the risk of dementia by 15%. This is the first real something that we have as clinicians to be able to look our patients in the eye and say, if you don't want to have dementia like your grandfather or like your father or your mother, this is something you can do to reduce your risk of having dementia. You can control your blood pressure and it will absolutely reduce your risk. Next slide, Mike. The second thing I want to make a point in the beginning of the presentation is what Mike mentioned earlier in his introduction, and that's team-based or interdisciplinary care of patients. This is a little bit of a hard nut for some physicians to take on, but they're really good studies that have demonstrated that rather than the traditional way of seeing a patient every 3 to 6 months, making decisions about their blood pressure management, to work with team members in your clinic, nurses, nurse practitioners, physician assistants, in some cases, community health workers, someone to touch base with the patient at least monthly, to encourage the patient to measure the blood pressure at home and have a reliable way of transferring that information. In some healthcare systems, that's done electronically. In some, it's still done with the patient keeping a log and bringing it in, but taking the average of their blood pressures at home over a period of a month, and then having a nurse practitioner or a pharmacist, sometimes a nurse, using a protocol that you have approved to make medication decisions in between the physician visits every 4 to 6 months. That way, Decisions are being made monthly to try to get the blood pressure under control. The safety of this has been demonstrated over and over again, and patients like it. The tenets, the key things that are there, number one is home blood pressure measurement, and depending on that for decision making. Number two is a protocol-based approach so that not only the physician at the point of care can make a decision about changing the medication or increasing the dose of the medication. So this is something that works. I hope that in your healthcare system that you are implementing this already, and if not, there's lots to read about, lots of information in the guideline about how to do this. And I just say this, I think, is something that can really make a difference in the rates of control in any clinic situation. Next slide, Mike. So as we move forward, we think about the key elements of decision making in making management decisions about blood pressure categories that helps us make a diagnosis, blood pressure threshold that helps us to know when to initiate medication, and blood pressure goal to help us to determine what we're aiming for in the patient and when we have control of the blood pressure, have reduced the risk for cardiovascular disease. Next slide. So from these key elements, we get what we report out in our studies of awareness rates, treatment rates, and control rates. Next slide, Mike. So here's one that I want to be sure you capture. So I'm asked all the time, did you change the goal of blood pressure? The answer is kind of. So our language for our blood pressure goal is to reduce systolic blood pressure to at least less than 130 millimeters of mercury, with encouragement to achieve systolic blood pressure of 120 millimeters of mercury. Let me say that for those of us who were medical students and trained during a period of time that we were told that there was danger in reducing blood pressure too far in older patients who had systolic blood pressure to start with between 160 and 200, that there were risks of stroke if the blood pressure was reduced too far. And we were encouraged to keep the blood pressure above 160 for safety reasons. Let me just say emphatically, we were wrong. It's the way I was taught. It's what I did early in my practice, like many of you. But I can tell you now, I am absolutely 1,000% convinced that we were wrong. We were just absolutely wrong. We did not have enough evidence for how to manage those patients. Most of the studies that we look at now that evaluate ideal goal blood pressure, either 130 or 120, are done in older patients. These studies have to be done for economic reasons, have to be done in high-risk patients. And in cardiovascular disease, that usually means patients. It's really, really important for us to grasp the idea that we were wrong about keeping blood pressure high, and that lowering blood pressure to the range of 130 to 120 is not only better at reducing risk of cardiovascular disease and dementia and kidney disease, but it's safe. It's safe to do that in our patients. It is, as we treat young patients and middle-aged adults, we can go as fast as we want to in lowering blood pressure. Again, most of you have the experience to know that in the older patients, we have to go slower, but going slower doesn't mean that we can't go down to these newly recognized improved risk remediation of 130 and 120 systolic blood pressure. Mike, we're going to look at a little data. Let's look at the next slide. So these are the studies that give us the 130 and the 120 goals and the comfort from them. And everything to the left of this line means that the patient did better, had fewer heart attacks, less heart failure, fewer strokes, all on that side. And you can see that every one of these studies shows a benefit from the lower. This top group is comparing less than 130 to greater than 130. The bottom group comparing less than 120 to less than 140. Those 130s a 22% reduction in cardiovascular disease, and comparing 120 and 140, an 18% reduction in cardiovascular disease. Next slide, Mike. Importantly, yeah, next one, Mike. Oh, there we go. You did. Okay. They look similar, don't they? Importantly, all-cause mortality was improved in most of those studies as well. I know there are other ways to evaluate side effects, adverse effects from a certain treatment, but it's reassuring. It's reassuring that the vast majority of these studies showed not only an improvement in cardiovascular outcomes, but an improvement in lifespan as well for those patients. Next slide, Mike. So one more slide of data just to make the point that lower blood pressures are the way our bodies were built. This is a study of middle-aged adults done by Seamus Welton at Johns Hopkins. He took a group of patients in a study who had normal blood pressure. So all of these blood pressures, these are the systolic blood pressures here, are below 130. These are people with normal blood pressure. All of these patients had normal cholesterol. They weren't smokers. They had no identified risk for cardiovascular disease. The dark bars represent diffuse coronary artery calcium as it was measured. And the lighter bars represent at least one piece of calcium that's recognized in the CT scan. And you can see that between 90 and 130, there's an absolute graded increase in risk in coronary calcium as the blood pressure goes from 90 to 130. I remind you, for those of you who haven't seen an obstetrics patient in a while, young women have blood pressures in this range. That's where they live. And we don't measure blood pressure in young men very often, but that's where most young men are as well. It's the way our bodies were designed. As clinicians, we get so biased by seeing so many people with high blood pressure that we're lulled into thinking, well, this is what blood pressure is supposed to be. This is normal blood pressure. These blood pressures are where our bodies were meant to function. Next slide, Mike. So a core element in your practice needs to be sure whoever measures the blood pressure knows how to measure it. The American Heart Association has lots and lots and lots of information available to you to train your staff, to train you in measuring blood pressure accurately. Office blood pressure is still important. The oscillometric instruments are the ones that we're recommending these days. But it's important to measure blood pressure accurately in the office, and also important to measure the blood pressure accurately out of the office as well. Next slide, Mike. These are recommendations around out-of-office blood pressure. You see both ABPM, ambulatory blood pressure monitoring, and HBPM, home blood pressure monitoring. And I'll say in my practice, I rarely use ambulatory blood pressure monitoring, but home blood pressure monitoring is a part of every single patient's treatment plan for them to measure blood pressure at home and keep a log of those blood pressures. We provide the corresponding normal numbers for office, home blood pressure, and ambulatory blood pressure monitoring as well. So this last little bit here, I want to be sure you see the third recommendation in this list is in adults. The use of cuffless blood pressure devices is not recommended for the diagnosis or management of high blood pressure. You have lots and lots of patients who are wearing watches, and the maker of those watches are telling them that it measures blood pressure. It doesn't. It doesn't measure it accurately or precisely. You should not, and your patient should not, depend on any wrist-worn device for measurement of blood pressure. There are very few recommendations in this guideline that say don't do this, but this is an emphatic one. Don't depend on wrist-based, watch-based blood pressure measurement for management of your patients. Next slide, Mike. And these are just simply reiterating the blood pressure categories. Normal is less than 120/80, elevated 120 to 129 and less than 80. Stage 1, 130 to 139 and 80 to 89. And stage 2, anything above 140/90. Next slide. So here's one that's that's important. What's in yellow there is the only new recommended standard test for every patient with high blood pressure. That's in this set of recommendations in the guideline. Still, all of those basic things, the CBC, electrolytes, creatinine, lipid profile, either a fasting glucose or a hemoglobin A1C, TSH urinalysis, electrocardiogram. But the new one is to try to pick up chronic kidney disease earlier than we've been doing that before. And that has implications both for the type of medicine that you're going to use and how aggressive you're going to get with your goal for that patient. For patients who have albumin in their urine, they're on their way to chronic kidney disease. They need to have their blood pressure to less than 120. And if they have albumin in their urine, they need to be on either an ACE or an ARB as part of their initial regimen for treating their blood pressure. Next slide, Mike. So now we move to therapy for your patients and lifestyle. There are very few changes here, but a couple of subtle things. We are again saying on dietary sodium, less than 2,300 milligrams per day, which is about a teaspoon a day. Most of your patients are getting their sodium from fast food, from processed food that they get at the grocery store. But they need to be conscious wherever they're getting their food. They need to be counting the sodium and trying to stay under 2,300 milligrams per day. We point out in this recommendation, the ideal is actually less than 1,500 milligrams per day. In today's American toxic food environment, it's pretty tough to do that. But we're just saying what the data shows, that this is ideal. Getting less than 1,500 is actually beneficial for managing blood pressure. Next slide. This is the recommendation regarding alcohol, and it's gotten less pushback than I thought that it might. I think part of that is because we're not the first health organization to suggest staying away from alcohol for health. The American Cancer Society, the World Health Organization, and others have put their foot down on this same type of recommendation. So let me read this. Adults with or without hypertension who currently consume alcohol should be advised to pursue a recommended goal of abstinence, or if they choose to drink, at least reduce alcohol intake to less than a drink per day for women and less than 2 drinks per day for men to prevent or treat elevated blood pressure and hypertension. The data on this is clear that beginning with the first drink, there's an adverse effect on blood pressure from drinking. It's not huge in most patients, but as most of you probably are aware, there's a big inter-individual difference in how people respond to alcohol. I've had patients who report to me drinking only a glass of wine with dinner at night, who, when I asked them to go on a month-long abstinence from that alcohol, had a dramatic improvement in their blood pressure. And some patients don't seem to have much change in their blood pressure with changing that small amount of alcohol. But this is what the data show, and so it's what we have recommended that you consider as advice to your patients. Next slide. And quickly, some of the other things related to lifestyle. Many of our patients these days are overweight or obese, and certainly weight loss is a huge factor in improving blood pressure. And people who are overweight or obese should be encouraged to lose weight. We'll talk about that more options for that in a moment. The DASH eating pattern is still the recommended food pattern that we encourage: high in fresh fruits and vegetables, whole grains, and low-fat dairy products, with careful attention to not too much saturated fat and total fat. Of course, keeping calories down in order to keep body weight at a good range. Next slide. And for the first time, we are recommending the use of a potassium-enriched salt substitute as one tool for the use of both reducing sodium and increasing potassium, both of which can improve blood pressure management. Pointing out it's particularly related to potassium-enriched salt substitutes and not the herbal salt substitutes. You get the double bang with a potassium-enriched salt substitute of a higher potassium level and a lower sodium level. Next slide. And exercise, of course, is an important tool for improving blood pressure. All three types of exercise, aerobic, dynamic, and isometric, are all useful in managing blood pressure. Next. So here is a new recommendation that won't surprise you. In adults with hypertension who are also overweight or obese, a BMI greater than 27, incretin mimetics, GLP-1 receptor agonist, when used for weight management, can be effective as an adjunct to lower blood pressure. So I don't know that it's critically important that we say this, but some of my colleagues think it's important to point out that these drugs on their own aren't great antihypertensive agents, but as you lose weight, blood pressure improves. So I personally don't think there's a need to parse it out like that. It's a low calorie diet does the same thing as you lose weight. As you lose weight, blood pressure improves. And then the second recommendation is for people, your patients who have more severe obesity, a BMI of 35 or above. Bariatric surgery is still something to consider as a management tool for those patients. There's some studies underway now comparing GLP-1 receptor agonist versus bariatric surgery for patients with hypertension, and which might be better. I think the bariatric surgery is going to win on this one, but we don't know that yet. But that's only for people with severe obesity. Next slide. All right, so good news. There's no change in this one recommendation. The same 4 classes of medication that have been recommended since 2017 are recommended again in this guideline. You know them well. Thiazide type diuretics, long-acting dihydropyridine calcium channel blockers, ACE inhibitors, or angiotensin receptor blockers. All 4 recommended as first-line therapy to prevent cardiovascular disease. Let me point out again, for those of you who trained during the period of time that I trained a number of years ago, beta blockers were a tool that we were asked to use to lower blood pressure. Beta blockers are no longer indicated for primary prevention of cardiovascular disease. There are indications, someone post-MI, some forms of heart failure, beta blockers are recommended for managing blood pressure and for preventing another MI or for managing heart failure. But for primary prevention, for your patients who don't yet have cardiovascular disease, only these 4 drug classes should be used until you hit a wall on the use of those 4 classes. Beta blockers are not in this group of drugs. Next slide. So back to the key elements of decision making. Blood pressure categories, we've noted no change. Number 3 here, the blood pressure goal, we've already talked about. Now let's talk about when we start medication on patients with high blood pressure. We're going to talk momentarily about the use of the new American Heart Association Prevent Risk Calculator in managing patients with stage 1 hypertension. Next slide, Mike. So here's the algorithm for when to begin medications on a patient with high blood pressure. So the first question at the top here is, does the patient have an average blood pressure greater than 140/90? That patient has stage 2 hypertension. You do begin medication on that patient along with lifestyle therapy. But everyone with a systolic above 140 or a diastolic above 90 needs to be on medication. For most of those patients, it's best to start with low dose of 2 drugs, hopefully in a single pill combination to help your patient with compliance issues. The second question is, does the patient have existing? So if the blood pressure is not above 140/90 and they have hypertension, that means they have stage 1. They're between 130 and 139 or 80 and 89. So if the patient is in that category, the next question is, do they have existing clinical cardiovascular disease, coronary artery disease, a stroke, heart failure? If the answer is yes, start the medication. Even if blood pressure is in the 130s, you go ahead and start medication along with lifestyle. If the answer to that is no, they don't have any pre-existing cardiovascular disease, you ask, does the patient have diabetes or chronic kidney disease or a prevent cardiovascular disease risk score, 10-year risk score greater than 7.5%. Probably most of you by now have food with the online calculator for Prevent. It adds the zip code as a marker for social determinants of health. I'll say that I was a part of some of the early research done on that, and I was skeptical that your zip code would accurately predict cardiovascular disease, but it is a strong predictor indeed. So I'm a fan of the new Prevent Risk Calculator. If you're above 7.5, or if you have diabetes or chronic kidney disease, go ahead and start medication. If the answer to all those questions is no, then you try 3 to 6 months of lifestyle therapy. Try to get the patient to really be engaged and try it enthusiastically at the end of 3 to 6 months. If the blood pressure is still above 130/80, then it's time to begin medications. This is different from the 2017 guideline. It does give you a plan for beginning medication on those patients with stage 1 hypertension if they don't respond to lifestyle therapy alone. Next slide, Mike. And then we look at your problem patients, the patients with resistant hypertension. The current definition: someone who has an office blood pressure above 130/80 on 3 or more antihypertensives that include an ACE inhibitor or ARB, calcium channel blocker, and a thiazide diuretic, or an office blood pressure less than 130/80, but it takes 4 antihypertensive medications to get them there. So you need to pause with that patient, evaluate them again for secondary hypertension, evaluate them for pseudo-resistance. Is the blood pressure being measured accurately? Is the patient's medication adherence okay? And then you need to screen for secondary causes. And you see I've highlighted primary aldosteronism. More and more studies that are showing that this is a more common problem than we once thought. And so our current guideline recommends more people, everyone with resistant hypertension, and then we ask you to consider the possibility of screening for primary aldosteronism if the patient has stage 2 hypertension or above. The Endocrine Society suggests screening everyone with any stage of hypertension for primary aldosteronism. Our recommendation, we're trying to find the balance between practical and what the evidence shows. And so our recommendation is for sure everyone with resistant hypertension. Consider it for patients with stage 2 hypertension above 140/90. And that's a renin-aldosterone ratio. And if you order that test and you're unsure how to interpret that test, there are people in your healthcare system, endocrinologists, nephrologists, et cetera, who can help you with interpreting that. In the past, we have stopped all blood pressure medicines to do this test. Today, the recommendation is only to stop mineralocorticoid receptor antagonist. Otherwise, all the other medicines can be continued while you're doing the screening. So if all of those are okay, if you don't find any identifiable reason for the resistant hypertension, then the next step is to consider a mineralocorticoid receptor antagonist, spironolactone or eplerenone. And if there's a contraindication to both of those drugs, if there's a contraindication to it, then next slide, Mike, then there's a group of drugs you can consider. But most patients can tolerate the mineralocorticoid receptor antagonist. Spironolactone in the right doses can be tolerated by most patients, including men. But eplerenone is safer for the men, not causing the gynecomastia that the spironolactone can cause. But for those of us practicing in the South, I'll just say that a lot of patients will respond to this. And I find myself in my practice, when I get to this stage with the patient and I start the spironolactone or the eplerenone, then within a few weeks, I'll be able to back off of some of the other medicines that they've been on because of the good response to the mineralocorticoid receptor antagonist. Next slide, Mike. And a new tool that is available, but I want to be sure that you hear me clearly, that this is a tool that is new. There's still uncertainty about its utility, when and how to use it. Clearly, most patients are not, quote, cured of their hypertension with renal denervation, but it can be a tool for people with resistant hypertension or patients who don't tolerate the standard medications. But before you refer the patient for renal denervation, our strong suggestion is that you refer them to a hypertension center, to someone like Dr. Moore or colleagues. Let them evaluate the patient for all of the potential causes that are reversible. And then if all of those tests are okay, then referral to the specialist who does the renal denervation would be an appropriate step. Next step. Next slide, Mike. Next slide. There you go. Okay. Yeah, there you go. Oh, yeah. Thank you. Go back one slide. I'm sorry. I missed that you had actually changed it. My bad. Yes, those two slides look too much alike. So here's a tricky one and a recommendation that's new. And again, I approached this issue with a good bit of skepticism, but through the process of evaluating the evidence as we wrote the guideline, became convinced of the direction that this recommendation needed to go. Early in my practice, in a patient who had orthostatic hypotension, almost always in my elderly patients. So seated, I give them enough medicine to get their blood pressure from where they started at 180 to down to less than 140. But when they stand up, get dizzy and the blood pressure goes to 90/60. Orthostasis is a very common problem in older patients, especially older women with severe hypertension. And in the past, our practice has been to let the blood pressure remain on the high side to avoid the orthostasis. There are good, solid studies that have demonstrated now what we recommend in our first recommendation here. In adults with hypertension, improved blood pressure control is recommended to reduce the risk for orthostatic hypotension. Improved blood pressure control. Slowly continue to lower the blood pressure to that goal of less than 130. And I will say most will tolerate that. It will be better than leaving the blood pressure elevated. Certainly lowers their risk to get the blood pressure down. So let me go to the next slide. And this is the magic from Dr. Guyton that teaches us why we can do that. So Dr. Guyton taught us that over a broad range of blood pressure, so blood pressure down here, brain blood flow here, it happens for the kidneys and the heart as well, but most of our symptoms are related to the brain. Over a wide range of blood pressure, brain blood flow stays constant. Okay, next slide, Mike. Next slide, if you will. So we see the ends of this in normotensive patients in these two conditions. In young women who experience preeclampsia, they can go from having normal blood pressures in the 90 to 110 range, and then they present to the obstetrics unit with a systolic of 180, where the patient who's 80 years old, you saw in the clinic yesterday, had that blood pressure and they were walking and talking and doing fine. This young lady, because she suddenly has a blood pressure this high, has hyperperfusion, increased blood flow to the brain, and symptoms of preeclampsia, including seizures. All right, so this happens quickly. The blood pressure changes quickly in preeclampsia. On the other end of the spectrum, your young adult male who is running a marathon gets dehydrated, and toward the end of the marathon, they get dizzy and may even faint because blood pressure, because volume is down, the blood pressure gets down below a systolic of 80, and they get symptoms of brain hypoperfusion, not enough blood going to the brain. You see that commonly in healthy people who get dehydrated. So next slide, Mike. When we're dealing with hypertensive patients, okay, let's go forward on 2 slides, if you will, Mike. Next slide. There you go. In a patient with chronic hypertension, what happens to the autoregulatory process is it moves as the patient's blood pressure rises. This curve moves to the right. So you still have a broad range, but it's occurring at higher blood pressures now. So your patient may be able to tolerate a systolic blood pressure of 200 to 220. They may be okay because blood pressure gradually goes up and the blood flow to the brain stays constant at a higher level. But you know what happens to those patients if the blood pressure gets too low, and too low for this patient isn't 80, it may be 110 or 120. where they fall off the autoregulatory curve. This is why we have to be very careful in managing our patients with orthostasis. We can't suddenly drop them from 220 down to 130. It has to be done slowly so that over a period of days and weeks, the autoregulatory curve can shift back to the left. In the past, we just let them stay up here to avoid any danger of being down here. Now, the therapy that's recommended is to slowly move them down so this whole mechanism, the whole autoregulatory curve, moves back down with them and they can tolerate the lower blood pressures. All right. It's okay if you're skeptical. I want you to try it on your patients. Try it carefully. All right. Severe hypertension and hypertensive emergencies. The patient comes with a systolic of 180 and a diastolic greater than 120. The question you ask, is there acute target organ damage? The answer is yes. The patient needs to be admitted to the hospital. That can be assessed from either symptoms or from imaging studies. If they're in heart failure, if they're having chest pain from coronary artery disease, or they have something like pheochromocytoma or aortic dissection, they need to be treated with intravenous medications to manage their blood pressure. The guideline points out in detail if they have either dissection or pheochromocytoma, then pressure needs to be lowered quickly in those patients. If they don't have either one of those conditions, then over 12 to 24 hours, the blood pressure is carefully lowered, but using intravenous medications to get there carefully. Next, Mike, if the answer to acute target organ damage is no, we don't call it a hypertensive emergency, but we simply call it severe hypertension. Wherever it's identified, if it's in your office or the ED or on the phone, the patient doesn't need to be admitted to the hospital if they don't have target organ damage. Either their oral medications can be adjusted, or what's often the case, as you well know, when they have blood pressures like this, they stop taking their medication, put them back on their oral medications, and follow them closely as an outpatient. Next slide, Mike. And there you go. No reason to refer these patients to the emergency room for evaluation. All right, as we close out, I just want to make an important point here. As primary care clinicians, as specialists, as we're managing a patient with high blood pressure, our ultimate goal shouldn't be disease modulation. Next slide, Mike. Our goal should be health for the patient. Our goal should be to help our patient to live a long and healthy life. And high blood pressure is the most common risk factor for cardiovascular disease. Cardiovascular disease is still the leading cause of death in our country, and is the leading cause of death in most countries around the world these days. Managing high blood pressure is a huge opportunity for improving the lives of our patients, longer and healthier lives. Next slide. So in conclusion, in adults with uncontrolled hypertension, any reduction in blood pressure is beneficial. But there's strong evidence for cardiovascular benefits in adults treated to a systolic blood pressure less than 130 and 120. There's also evidence that lower blood pressures reduce the risk of cognitive impairment and dementia. Implementing guideline recommendations for target blood pressures should be a very high priority for all of us in our practices. Next slide, Mike, and I thank you for the opportunity to present. I hope you have some hard questions for me and for Mike, and thank you for your attention and for the privilege to be with you tonight.
Thanks, Dr. Jones. Renee, do we have anything in the chat?
At this time, we don't have any questions in the chat. However, if anyone have any questions, you can put them in the chat, and then I can present them to Dr. Jones, or you can speak up.
Right.
You can do that at this time.
I have a question.
Dr.
Kaplan, can you hear me?
Yes, we
I hear
can.
you. Yes,
Yeah.
Dr. Kaplan.
Wondering if you've all looked at, and I mean for current recommendations or future recommendations, and I bring it up, the Catalyst trial. Dr. Ralph DeFranza, who does diabetology, gave a lecture at the ADA the end of the year, looking at the Catalyst trial, because yeah, it's true, secondary hypertension from things like sleep apnea, pheo, renal artery stenosis, hyperaldo, but they found diabetic patients with multiple blood pressure medicines, poorly controlled, 35% of them had hypercortisolism, not Cushing syndrome, but an abnormal dexamethasone suppression test. that if it were treated with medicines on the market and improve both hypertension and diabetes. Was the Catalyst trial looked at, or are you familiar if it's being considered for future recommendation for secondary hypertension evaluation? Because Cushing's is so rare. We're talking about this as 35% is quite high.
Indeed, Dr. Kaplan, thank you for your question. We did look at that, and I guess the short answer to why it's not in the guideline is waiting on some confirmatory studies on that issue. Just as I pointed out, that we're now recommending that primary aldosteronism be looked at, screened for in more patients than we have in the past. I think this indeed will be another one that will eventually make its way into the guideline to screen for hypercortisolism. High cortisone levels, and I think that we will eventually get there. I do. Yeah.
Good. Yes, from the ADA point of view, like, I don't know, Ralph DeFranco is nationally known. He kind of said, oh my gosh, we have literally missed this our entire lives. It's been out there right in front of us, and we didn't even understand that it existed.
So, this what we have referred to for a long time as essential hypertension or primary hypertension. We know that a large number of those patients that we can't identify some specific reason for their high blood pressure, there are many of them who have. We're understanding genetics more. There will be more and more genetically understood causes, and just as the ADA study demonstrated yet another pathway for a lot of patients with high blood pressure. We have to continue to pick at all of those patients who we say, well, we don't know what causes it, but here's some good medicines to try. More and more, we're going to move toward personalized medicine, individualized medicine, and more studies being done these days. High blood pressure is such a huge problem, and we won't ever run out of reasons to continue our research to try to understand it better.
All right. Well, thank you for your answer. Enjoyed your lecture.
Thanks so much, Dr. Kaplan.
Renee, I think there's something in the chat. Is there some questions in the chat?
Yes, it is. And then we have Dr. Pradhan. He can go, and then I'll read the 2 questions in the chat.
Dr. Pradhan, one of our internal medicine docs, please.
Dr. Jones, thank you very much for a wonderful talk. And again, going back to the basic thing was salt intake, and you pointed out appropriately how much salt. And second thing is non-compliance, not taking the medication. 2-part question. One is hypertensive patient on diuretic and ACE comes with a hypokalemia. Have you tried supplementing with mineralocorticoid versus adding and supplementing potassium? The reason I'm bringing this I've tried to do this because potassium pill is large, and elderly patients complain about swallowing, and sometimes they don't swallow it, get choked on. That's the one part. A second question is screening for Aldo. What is the best workup you do in primary care office? Thank you.
Yeah, I think in the primary care office, it begins and ends with a renin-angiotensin, a renin-aldosterone ratio. And if that test is abnormal, I think it's time to refer the patient either to an endocrinologist or to another hypertension specialist in nephrology or cardiology. But it's getting past that. I'll say there are lots of ways to evaluate those patients, but I think best done in the hands of someone who does that day in and day out. Back to your other question. First of all, that patient who is on an ACE inhibitor or an ARB and a diuretic and has hypokalemia does need to be screened for primary aldosteronism. That's in a sense, even though they're on a diuretic because they're on the ACE or ARB, in a sense, it's unprovoked hypokalemia. But yes, it's not unreasonable to consider adding a mineralocorticoid receptor antagonist to that regimen. Part of the reason we don't use those drugs more is there simply haven't been enough studies to demonstrate their safety in that kind of situation. I had a good, smart friend ask me a few days ago when we were discussing just exactly what you pointed out. Why are those drugs not in the recommended first-line drugs? And it's because they've not been tested as single agents in their ability to prevent cardiovascular disease. I think if they are ever tested that way, we'll find that they are as good as the 4 that are in that class now. Thanks for great questions. Thank you.
Thank you.
Dr. Jones, we have a couple of questions in the chat. One being, any updates on preferred medications in a person with chance of pregnancy?
Yes, so I can't name them off the top of my head, but we did expand slightly the list of drugs. Still, the main drugs that are used are the dihydropyridine calcium antagonist are the safe ones, but there have been a couple of drugs added to it, and I don't want to risk misstating what those are, but in the guideline, there is a section on pregnancy and management of blood pressure during pregnancy, and those drugs are listed there. Mike, do you know those offhand?
Dr. Jones, let me just mention to everyone, on the invite you received to register for this program, we put the link to the report. So you can click on that link if you'll go back to your registration invitation, and it'll take you right to the full report. You can drill down to the pregnancy section. If anyone can't find that, if you'll just email me or Renee or Jennifer, we'll send you the link. And you can just search it. It'll pop right up on any search, 2025 high blood pressure adult guidelines. It'll pop up from circulation and multiple other journals. Okay, go ahead.
Yeah, thank you, Mike. Yeah.
And then your last question in the chat is, any guidance on trying to control blood pressure in persons with autonomic dysregulation?
Yeah, so yeah, right. So if you solve that problem, you'll be famous. I can't tell you the frustration of trying to deal with those patients. Yeah, we don't have answers right now. We don't. I'll say that most clinicians think that getting blood pressure regulated as much as you can in the standing position is the best you can do. And sometimes a patient who is hypertensive in the supine or seated position with autonomic dysfunction just can't tolerate any antihypertensive medications. But I think you just work with each individual patient and do the best you can to get their seated and supine blood pressure as controlled as possible, still allowing them to not be too hypotensive when they stand. It's a tough
problem. It is.
It's a tough problem. I have that this, I'll just say that when those patients come to me, I would walk out of the exam room and shake my head and tell a resident, these doctors keep sending me these patients with autonomic dysfunction. I need to call them and tell them I'm a hypertension doctor, not a hypotension doctor.
Yeah.
So
anyway, you have to understand that your autonomic nervous system is the ultimate blood pressure regulator. It's not renin-angiotensin aldosterone. So when you're adding multiple medicines together, one of the reasons that we put sympatholytic agents at the very last drugs you consider, those are drugs like alpha-methyl-dopa, clonidine, is because when you take out the sympathetic nervous system, you create really therapeutic autonomic dysfunction, if you will. That's how you're trying to get the drug to work. So it's really a tough problem. And some patients have primary autonomic dysfunction, so-called Schein-Drager syndrome, and they're even worse to deal with. Any last questions before we close with Dr.? You got the guy here, so he is the man that knows. Any last minute questions? Okay.
Yes, well, thank you. Thank you very much, Mike. Thank you for the invitation, and thanks for this opportunity to be with you. It's been a real privilege for me.
It's our privilege to have you. Let me remind everyone that next Tuesday we'll have our first online nursing specific or centric program. If you haven't gotten an invite and you want to get one, let one of us hear from you. And then in 2 weeks, David Calaba will talk about heart failure. Short of that, I would just tell you that if you're a John Gresham fan, his newest book's terrific. And we appreciate Dr. Jones so much. Have a great evening. Thank you for being with us. Try to stay warm. It is getting warmer. The snow's melting. Take care. We'll see you back real soon. Bye-bye.
Thank you, Dan.